Happy to be back in a new year and seeing everybody. And we have Dr. Daniel Solomon here today, and I'm going to turn it over to Dr. Schlesinger, who's going to be introducing Dr. Solomon. You're on mute.
Good morning, everyone. It's really a great pleasure to start the year with a very prominent rheumatologist, Dr. Solomon, a professor of medicine at the Harvard Medical School, who serves as the chief of the section of clinical sciences, the division of rheumatology at the Brigham and Women's Hospital. He's an expert in rheumatic disease epidemiology with a focus on drug safety and cardiovascular disease and outcomes. His research is funded by NIH, AHRQ and Foundation. His main research interests have been cardiovascular safety of non-steroidal anti-inflammatory drugs, cardiovascular manifestations of rheumatoid arthritis and its treatment, and also defining standards for osteoporosis care and improvement. And really, he's played a prominent role in academic publishing, having authored over 800 manuscripts and serves as the editor-in-chief of our premier American Rheumatology Journal, Arthritis and Rheumatology. I could talk probably 10 minutes at least about him. So to sum it up, really, Dr. Solomon is one of our leading rheumatologists today in the world. He plays a leadership role at the Brigham and Women's Hospital, Harvard, and major roles also at the American College of Rheumatology. So it's a great honor for us to have you, Dr. Solomon, give us our first grand rounds of 2021. Thank you so much.
Thank you, Naomi. Thank you, David. Let me share my screen. Okay, so today we're going to be talking a little bit about cardiovascular disease in RA and using it as an example of the inflammatory basis of atherosclerosis. So it's a real chicken and egg dilemma, RA and cardiovascular disease. Is the RA causing cardiovascular disease, or some of the treatments for RA causing cardiovascular disease, or are there shared causal factors for both RA and cardiovascular disease? And as an epidemiologist, I find this fascinating. And as a rheumatologist, I find it incredibly important as a topic to discuss with my patients. So today we're going to explore some of these issues, and we'll start with a case which I always think helps frame the issues. This is a patient of mine, a 51-year-old female with 12 months of disease. She has hand pain, treated with ibuprofen, occasional steroid tapers, minimal improvement with 1 to 2 hours of morning stiffness, but no functional limitations at this point. Medical history includes hypertension. She has no known coronary artery disease. She's overweight with a 25-pack year history of tobacco use, quit in the past year. The medications include a beta blocker and ibuprofen. So a very common presentation. She, on exam, shows that she has bilateral metacarpal phalangeal synovitis, MCP synovitis. She has no nodules or deformities on exam. Her blood pressure is slightly elevated and the pulse is 90. And as I do with most such patients, I would send labs. I'd educate them about rheumatoid arthritis, as this is my number one on the differential diagnosis. And I'm going to follow up her labs and discuss treatment options after we learn more and she's had a chance to digest the discussion. So the laboratory workup revealed that she is anti-CCP positive with an elevated HSCRP. The hepatitis panel is negative, normal liver function tests and thyroid tests, slightly anemic, no erosions on x-rays of hands and wrists, as shown in this representative x-ray, and her chest x-ray is negative. She continues to have bilateral hand pain and stiffness when discussed with several weeks later. And so the discussion with KCT is, what would the treatments be, and would they be at all influenced by her cardiovascular history? And that's what we'll talk about today, and we'll come back to this case later on. The underpinnings of CVD and RA are important, and we'll start with that. We'll talk about risk stratification of cardiovascular disease in RA. Risk stratification really becomes a way of translating the epidemiology into the clinic. We'll consider an evidence-based approach to cardiovascular disease, management and treatment in RA, and then we'll think a little bit about the etiopathogenesis linking RA and cardiovascular disease, really without any solid answers at this point. So this is a slide that I borrowed from my colleague Paul Ridker in cardiovascular medicine here at the Brigham, and he shows this to the first-year medical students at Harvard, showing the link between the atherosclerosis in the aorta on the left, and making the point that the inflammation that's driven by the atherosclerosis and is part of the atherosclerotic process on the left is very similar to the process in rheumatoid hands on the right. You know, and this stems from his work, much of it epidemiologic work dating from the late 90s, where he looked at cases and controls from the Physician's Health Study and saw that the relative risk of myocardial infarction was increased along quartiles of IL-6. This is similar for quartiles of HSCRP. Again, a similar design, cases and controls in the Physician's Health Study, showing this relationship with important inflammatory markers, IL-6 and HSCRP. As you know, many of you know, this story with HSCRP evolved over the next decade, where at least 50 plus prospective cohort studies showed a relationship between HSCRP and coronary heart disease on the left and vascular death on the right. It was a graded response. As the HSCRP increased, the risk ratio for CHD and vascular death increased as well. This relationship to HSCRP and cardiovascular disease is not just an academic issue, though, because when we look at the relationships comparing HSCRP to blood pressure or total cholesterol or LDL, we can see that the magnitude of the relationship, the adjusted risk ratio for HSCRP per standard deviation, is very similar to the relationships for blood pressure, cholesterol, and LDL, well accepted risk factors that we think about risk stratifying patients with, as well as managing patients using cardiovascular treatments for these issues. So this really was part of the argument to bring inflammation into the clinical management of patients with atherosclerosis. And Paul Ridker's first attempt at this was the Jupiter trial. Many of you are familiar with this, published over a decade ago. This was Crestor or rosuvastatin at 20 milligrams a day compared to placebo in 18,000 patients. And the importance here is that patients did not have elevated LDLs. They were all below 130. They all had elevated HSCRPs, and none of them had a history of coronary artery disease. And even though they had no elevation in LDL, there was the appreciation of a 44% reduction in the hazard ratio for cardiovascular events. And this translated into a number needed to treat over 5 years of 25 patients. But obviously, rosuvastatin isn't just working on inflammation as a lipid-lowering agent or a statin. Here, what I'm showing you is that at the same time that HSCRP on the bottom panel is going down, we also note important reductions in LDL. So the question remained after Jupiter was whether the large benefit observed was due to lipid lowering or due to inflammation inhibition, or a combination of these two processes. The other important finding that I take away from Jupiter was a paper also published in the New England Journal by one of my colleagues, Bob Glynn, a biostatistician with a long interest in venous thromboembolic disease. And Bob published this paper showing that the risk of DVT or PE was also reduced in the rosuvastatin arm. And this is so interesting because we know that VTE is not an atherosclerotic condition. It's really a condition much more closely linked with inflammation. And so taking from this finding, we got interested in the relationship between VTE and rheumatoid arthritis. And I'll show you a little bit of data on that in several slides. But summarizing this prior work on inflammation and cardiovascular disease, my colleague Peter Libby former chief here at the Brigham in cardiovascular medicine, developed this cartoon a decade ago where he's showing both the adaptive immune system, T cells, and the innate immune system being quite important here, macrophages, interferon, gamma elevations in response to the lipid-laden macrophages and the atherosclerotic plaques that we see so commonly in patients with coronary artery disease. But this was really a first attempt a decade ago at trying to unravel how inflammation might impact and underpin atherosclerosis. Fast forward 7 years to the publication in 2017 of the CANTOS trial. Again, my colleague Paul Ritker and others looking at canakinumab, an IL-1 beta blocker, IL-1 having an important influence on cardiovascular disease. They tested 3 different dosages of canakinumab, 50, 150, and 300 milligrams by IV every 3 months. The primary outcome listed is myocardial infarction, non-fatal stroke, and cardiovascular death. And it was noted that the hsCRP dropped by 30 to 40% in this population. And as you can see in these bottom panels, the canakinumab 300 arm, as well as the canakinumab 150 arm, reduced the risk of cardiovascular events by about 15%. So again, this was really further proof of this, the importance of inflammation, in this example driven by IL-1 blocked by canakinumab for underpinning atherosclerosis. Here we're looking at the general population, but in a minute we'll turn our attention to rheumatoid arthritis. The updated cartoon of inflammation, can be described here, and what we're showing is the oxidized LDL, the inflammatory component of LDL, and cholesterol crystals impact the macrophage through kind of a double, a 2-stage effort, through priming as well as through being taken in and impacting the NLRP3 inflammasome, which produces IL-1 beta, and then eventually there's pyroptosis. So we know that canakinumab will block the effects of IL-1 beta after it's released, but we can also hypothesize, and as rheumatologists we think a lot about this, how colchicine impacts the generation of IL-1 through the NLRP3 inflammasome. So I'm sure this audience is very familiar with now the burgeoning literature on colchicine in coronary artery disease. Here, I'm just showing you one trial, the LODOCO-2, published this year or 2020 in the New England Journal, a double-blind randomized trial with 5,500 patients with chronic CAD taking colchicine 0.5 milligrams daily. Primary outcomes listed here, an expanded MACE, and followed for a little bit over 2 years. And you can see that there was a 30% reduction in the cumulative incidence of the CV death, as well as stroke and urgent hospitalization. So this was really further proof for many of us that anti-inflammatory immunomodulatory agents can have an important impact on coronary artery disease. It's interesting to note which of the components of the composite outcome were impacted by colchicine. You can see that many of them were. It's quite interesting, again, to note that death from any cause was not reduced. Again, pretty wide confidence intervals, but this has been noted in other colchicine trials, and it deserves further follow-up. Not really clear at this point why that might be the case. Now let's turn our attention back to rheumatoid arthritis so we can contextualize patient CT. Again, here's this slide, and as all the rheumatologists in the audience will tell you, the inflammation of athero may be quite different than the inflammation of rheumatoid arthritis. There's certain aspects of it that are quite similar, certain pathways that are quite similar, but it's likely that there's components that are different. And, we started looking at this almost 20 years ago now. These are data that we generated from the Nurses' Health Study, looking at patients with rheumatoid arthritis, comparing them to the non-RA population, looking at the incidence of myocardial infarction. And we saw that there was about a doubling of the adjusted risk of myocardial infarction, a 50% increase in the risk of stroke. The stroke risk was not statistically significant, but the adjusted MI risk was. And we've gone on to look at this in multiple other populations. Here, we're looking at an RA population from British Columbia. It's a large administrative database we find 25,000 patients meeting our definition of RA. We match them 10-to-1 to patients without RA. So quite a robust population. And here I'm showing you the rates per 1,000 person years. And you can see that the over 1,000 events in the RA compared to 6,400. But when we look at the event rates, 14.8 compared to 9.1, giving us a rate ratio of 1.6. And this has been a consistent finding, about a 50% increased risk of cardiovascular events across patients with rheumatoid arthritis compared to the general population. Again, I mentioned before the work of Bob Glynn, looking at venous thromboembolic disease and its relationship to inflammation. And here, this is a very recently published work from some Swedish colleagues based on registry, 46,000 patients with RA matched 1-to-5 to the general population. On the top, I'm showing you that within RA, between disease activity categories, so the DAS28 is our standard disease activity measure, low, intermediate, and high, and you can see that there's a graded increase of venous thromboembolic disease being reaching a doubling of risk in patients with high disease activity. When we compare this to the general population, we can see a 90% increased risk compared to the general population. And in the high disease activity, it's almost a threefold risk increase. So this is quite interesting work. Again, very suggestive circumstantial evidence that disease activity, inflammation in rheumatoids, similar to the general population, may be associated with venous thromboembolic disease as well as coronary artery disease. Let's take some of this epidemiology that I've shown you and think about how we might apply it to patients that we're seeing in the clinic. And again, I think that this area is a great example of translational research, where we take, kind of phase 1, phase 2, and translate it into the clinic in translational 3 and 4 types of research. And we started on this work using data from the Corona registry. Corona is the largest global registry of patients with RA, has over 50,000 patients with rheumatoid arthritis now. When we started this research over a decade ago, we were looking at 10,000 patients with RA observed for a median of 2 years. We looked at traditional cardiovascular risk factors listed here, and we looked at RA severity measures, including duration of disease, serologic status, disease activity, measured by the CDAI, nodules, erosions, history of total joint replacement, functional status as measured by the health assessment questionnaire. And then we found that there were 76 cardiovascular events for a incidence rate of 4 per 1,000 person years. And when we look at how the RA markers of severity and the cardiovascular risk factors interact, you can see that this green bar in the back left corner, where patients have more RA markers of severity and more CV risk factors, really gives us the highest risk. So what we suggested here, and we showed this again in the area under the receiver operating characteristic curve, is that RA severity contributes to typical cardiovascular risk factors and improves the ability to predict future cardiovascular events. We've gone on to look at this in several other studies. This is published in 2015 in Arthritis and Rheumatology, again using data from Corona. Here we have 25,000 patients with RA, all of them on disease-modifying agents. looking at the time averaged clinical disease activity index, again, our disease activity score that we have in Corona. We used modeling including age and sex, and then we added in cardiovascular risk factors, and then we added in medications as well as RA risk factors. And what you can see here is that when we look across disease activity scores, similar to what I showed you from the Swedish registry with respect to venous thromboembolic disease, when we look at patients in high disease activity, here they're the reference group with a hazard ratio of 1. You can see that the relative risk or the hazard ratio for cardiovascular events is decreased across disease activity measures, moderate in light gray, low in dark gray, and then remission in black. You can see that lowering someone's disease activity through more intensive treatment seems to be associated in this epidemiologic study with a reduced risk of cardiovascular disease, similar to what I showed you for the VTE risk from Sweden. This has been looked at in other data sets as well. This is data from a colleague, Jeff Curtis at UAB. He's looking at the multi-biomarker disease activity index, otherwise known as VECTRA. This is a proprietary biomarker panel. It measures 12 analytes listed here. A number of these analytes are important biomarkers, both in inflammatory disease as well as in cardiovascular disease. And what Jeff and colleagues saw was that as the quartile of the MBDA score goes up, the incidence rate of MI goes up, the incidence rate of coronary heart disease goes up. So again, another way of looking at this gradient of risk across the disease activity as measured by a biomarker panel. There is an interesting phenomenon that some people may have heard about called that's been dubbed the Lipid Paradox. It was first described 10 years ago by some colleagues at the Mayo Clinic. Here's data from Elena Maisadova. And what she showed here is that as the, here, let's look at the LDL. As the LDL increases, the hazard ratio for cardiovascular disease seems to go down in a population of rheumatoids. And this was, again, dubbed the Lipid Paradox and has caused a lot of interest and further study. And, we've taken a look at this. This is my colleague, Kat Liao, and myself and other colleagues here at the Brigham. And we looked here at a large population of patients that we have from the Brigham health system, looking at the odds ratio for major adverse cardiovascular event, or MACE, in rheumatoids by their LDL level and by their HDL level. And what you can see is that we also see this reduction in the odds ratio for MACE at this low level of LDL, and then we start to see it go up, and we see a very similar curve for HDL as we might anticipate from the general population. And then Kat did something very intelligent, and she looked at this in the non-rheumatoid population and actually saw a curve that looked quite similar in the RA and the non-RA populations, both for LDL and for HDL. So again, kind of just adding some interesting information to this concept of the lipid paradox, which we'll come back to a little later. But the lipid paradox and looking at other risk factors that are traditional cardiovascular risk factors has not proved as beneficial for risk stratifying patients with RA and their cardiovascular risk as we would have hoped. And these are data, again, from the Mayo Clinic. These are data from the American Journal of Cardiology, 2012, Cindy Croson. And what she looked at here was decile of predicted risk by the Framingham risk score. So 525 patients with RA, a mean follow-up over almost 10 years, not that many cardiovascular events. And the Framingham risk score was based on measured characteristics. And the point that she's making here is that the FRS, the Framingham risk score, underestimates risk. So the predicted in the white bars is much lower than the observed in the black bars for multiple of the deciles. And this has troubled many of us, and it's pushed a number of us in this area to want to develop RA-specific risk stratification tools for cardiovascular disease. And so this is our attempt at doing that. This is what we dubbed the Corona ERS-RA, the expanded risk score for RA. And this is a study where we looked at development and validation of a expanded risk score. And what I'm showing you here is the area under the receiver operating characteristic curve for the base model, which is the Framingham risk score in red, and then our expanded risk score model in blue. And you can see that the area under the receiver operating characteristic curve improves. It looks quite slight. It's statistically significant. And the RA risk factors that we added after a very laborious analysis were the disease activity index, the functional status, MHAC, the prednisone use, any versus none, and disease duration of at least 10 years. So when you add in those 4 risk factors to the Framingham risk factors, we see an improvement in risk stratification. And what we did here in this kind of busy table was that we showed how when we look at the expanded model compared to the base model, that we are able to recategorize or reclassify patients. These are the green arrows showing you that the actual event rates in the in this expanded risk score model are improved compared to the Framingham risk score model. And most importantly, the net reclassification index is 40%. This is quite large improvement in net reclassification. And it turns out that 17% more RA patients would have their their cardiovascular risk correctly classified by using the expanded risk score. There is one category where it seemed to perform less well, but that's common and important to look at all these different risk categories. The ERS has been tested in external data. Again, this is a collaboration we have with some colleagues from Sweden using some Swedish cohorts published in 2019. And again, they look at predicted versus observed risk using the expanded risk score and find that it has high calibration here with a C statistic of 0.74. So this has been looked at now in this population, and then there's some other papers that I'm involved with or familiar with from other populations testing the expanded risk score. We've put the expanded risk score on our website, and if you're interested, you can actually sit and use an Excel spreadsheet and show patients how modifying their risk factors will change their 10-year risk of cardiovascular disease. So now let's take this data, the data on the general population, the data on risk stratification, and consider an evidence-based approach to cardiovascular disease in RA, specifically thinking about how treatments might impact a patient like CT. Again, just to remind you, she's a middle-aged woman with cardiovascular disease risk factors, but no known disease. She has, the question she's asking is what DMARD should be offered, and should her CV risk profile influence this? And the questions that I'm going to discuss today with respect to treatment surround methotrexate, TNFs and other biologics, steroids, and then non-steroidals. And I think most people are familiar with the literature around methotrexate and cardiovascular disease. And this was a meta-analysis that I was involved with about a decade ago, looking at a number of observational data sets and suggesting that use of methotrexate in patients with inflammatory rheumatic diseases, RA and psoriasis, associated with a 21% risk reduction in cardiovascular disease. And this work was very important in informing the trial that called the CERT trial, which again, Paul Ritger, one of my colleagues here in cardiovascular medicine, undertook with support from NIH. And I had the opportunity to be involved with this trial. It was quite something with hundreds of sites from US and Canada. And I was, my job was to try to keep patients safe on methotrexate. And it was quite something we had a team of 5 rheumatologists, and we really did very intensive follow-up of these patients on methotrexate. And we were able to keep patients safe on methotrexate. And as Naomi and other rheumatologists know, we've been able to publish a lot on the safety of methotrexate involved through the data from CERT. But what I'm talking about today is really the cardiovascular impact of low-dose methotrexate used at 15 to 20 milligrams per week. All the patients that were enrolled in CERT had prior MI or known CAD. They all had known diabetes or metabolic syndrome, which was the surrogate for increases in inflammation. So the NIH did not allow us to use CRP as a baseline exclusion or inclusion criteria because of some kind of interesting legal issues. The primary endpoint here was MACE. The trial was stopped, unfortunately, because of futility. And I think, again, this is the cumulative incidence curve. I think most people have seen this published in the last year or so in the New England Journal. And again, it showed that there was no improvement on low-dose methotrexate and the risk of cardiovascular disease. And the question that I'm asked by my rheumatology colleagues is, so why did low-dose methotrexate fail in this population? And this is not a discussion of specifically a methotrexate today, but I think the alternative hypotheses would be, first, methotrexate simply doesn't work for cardiovascular disease, or these patients didn't have enough inflammation, or perhaps it's some combination of the two, that a general population group, unlike a rheumatoid population, has different pathways that are upregulated associated with their cardiovascular disease. So I think it's an interesting question that we don't have the answer to, but clearly methotrexate is not the treatment of choice in patients in the general population who have atherosclerosis. However, other treatments might be more promising. And this is some observational data published almost a decade ago in Circulation from Scandinavia, 17 patients with active rheumatoid arthritis. They were compared to 34 patients with stable known cardiovascular disease. The RA patients had a mean of 58 years. They had a CRP of 11, and they were all starting on an anti-TNF agent, either Enbrel or adalimumab. And the DAS28 was in the highly active range. And what you can see here is the results by FDG PET-CT. And as some of you know, in the vascular studies of FDG PET-CT, we look at the aortic total to background ratio, the TBR, and then the TBR in the most diseased segment, MDS. And what you can see is that there's a significant, clinically and statistically significant reduction over 8 weeks after the start of a TNF agent in both these measures generated by the FDG PET-CT. This is an open label cohort study. And the inflammation measured by the FDG PET-CT was larger in the vascular beds in these rheumatoids compared to other patients with known CVD. So this was a very interesting study which influenced many of us who were thinking about how to study different treatments for RA with respect to cardiovascular outcomes. And again, there's observational data. Some of this I've been involved with, suggesting that TNF agents are associated with about a 30% reduction in cardiovascular disease events. This is a meta-analysis of observational studies, and you can see a fair consistency across many studies suggesting that TNF agents are associated with a risk reduction in cardiovascular disease. Interestingly, and you might have anticipated this, when we look at cardiovascular disease mortality by decade, these are data that were generated by some colleagues in Norway and just published recently. They show that patients that were observed in the 90s or in this period when TNF agents were just starting to penetrate the market, or more recently, you can see all-cause mortality in rheumatoids dropping and cardiovascular disease mortality dropping. Again, suggesting that more intensive treatment, perhaps the use of TNF blockers, might be associated with better cardiovascular and overall mortality in rheumatoids. This has informed us in developing a trial, which we're now almost done with. This is called the TARGET trial. This is an NIH-funded trial that I'm running with my colleague Joan Bathon from Columbia. We had 35 sites from around the US, and we're able to enroll 162 patients. And we're now just doing follow-up on those patients. And we will unblind in May and examine their FDG PET CTs. They were all patients with active rheumatoid arthritis who had been methotrexate inadequate responders. They were randomized to get add-on a TNF agent, a etanercept, adalimumab, or triple therapy. This is sulfasalazine and hydroxychloroquine plus methotrexate. We looked at them over 26 weeks with an FDG PET at baseline and an FDG PET at the end of study. And again, the primary outcome is the change in the vascular inflammation as measured by FDG PET CT. And so we'll be reporting those out in the summer and the fall. There are some concerns, however, with biologic DMARDs, and this is something that has kept a lot of rheumatologists up late at night when prescribing. You know, we know that the IL-6 blocker tocilizumab, as well as Kevzara, another IL-6 blocker, are associated with increases in LDL and total cholesterol. We know that JAK inhibitors, tofacitinib, which is Xeljanz, also associated with some increase. And there's even data for some studies suggesting that TNF inhibitors might have a slight increase in the risk of dyslipidemia. So this is provoked the FDA to ask the makers of the IL-6 blocker Actemra, tocilizumab, to study this in observational data here. This is a large observational study that we did here in the Division of Pharmacoepidemiology with some colleagues from Genentech, the makers of tocilizumab. And what we found was no increased risk when we look at tocilizumab users compared to TNF users in their risk of cardiovascular events. You can see here, there's a hazard ratio of 1. And then there was an observational, or this is a randomized controlled trial published in the last 2 years in A&R, looking at tocilizumab versus etanercept with 3.2 years of follow-up. Again, primary endpoint was MACE. And if we look at the cardiovascular outcomes, you can see hazard ratios that are no different than 1. So observational data on cardiovascular events in IL-6 blockers, no different than the randomized trial data. And both of those suggest that IL-6 blockade does not cause an increased risk in cardiovascular events compared with TNF blockade. So this is an important finding and important for us as rheumatologists when we prescribe these drugs. Thinking about other drugs, steroids. Steroids are rheumatologist's best friend. And Philip Hench won a Nobel Prize in the late 40s for corticosteroids curing rheumatoid arthritis. Obviously, they don't cure rheumatoid arthritis, and they cause a lot of side effects. One of the issues that's been noted over the years is the risk in cardiovascular events. This is a very large meta-analysis, 236,000 patients, over 500 cardiovascular events. Corticosteroids were associated with a 50% increased risk of cardiovascular events. Now, one of the difficulties here is that we know that steroids are given to patients who are having active disease. And so to some extent, unscrambling the relationship between disease activity and corticosteroids is like unscrambling an egg. And so what we're looking at here is we're not quite sure if this is the steroids or the disease activity associated with these cardiovascular events. So confounding by indication is the epidemiologic term that might underpin potential bias. Also, these are data generated from the Precision trial. This was the very large celecoxib trial mandated by the FDA. Pfizer took them, 8 years to enroll enough patients. Here is data that we published in A&R separating out the patients with osteoarthritis and rheumatoid arthritis. But what we're showing here is the cumulative event rates in celecoxib in the light orange, and naproxen in the gray, and ibuprofen in the darker orange. And you can see that there is some difference in risk, perhaps celecoxib being slightly less risky than these other agents. But we worry about NSAIDs in our patients with osteo and rheumatoid, especially the rheumatoids with an increased risk of cardiovascular events. And so these are really contraindicated in patients with any recent cardiovascular events, and they may underpin some of the risk that we observe in cardiovascular disease in our patients with rheumatic conditions. So again, coming back to CT, what DMARD should be offered? Methotrexate's first line. Methotrexate, while we don't, the CERT trial shows us that it's not protective in general population. We still don't know that for sure in rheumatoids, but we, as rheumatologists, have been giving methotrexate for 40 years. It started in pediatric acute lymphoblastic leukemia, went to dermatology, then to rheumatology in the 80s. It's tried and true. 60% of patients will have good response. That response may wane over time. And obviously there's a lot of monitoring that we do, but we cannot tout the CV benefits of methotrexate at this point in RA. Should her CV risk profile influence this? Yes, clearly it should, but we need better risk stratification tools. I showed you the ERS-RA. There's continued work on this area. Can we use more biomarkers? And there's a lot of, studies going on trying to improve our ability to risk stratify rheumatoids with respect to future cardiovascular events. And we clearly need a better understanding of which DMARDs might impact CV risk. And that's why precisely we're doing the target trial. And there's other studies attempting to look at this as well. I just want to finish with the question that has to be lingering in your mind. I showed you initially a slide about RA and an arrow to cardiovascular disease. So what might be the links? And I've talked about inflammation, but as a rheumatologist, I want to be more specific about what aspects of inflammation. As well, I talked about the possibility of medications. I've showed you about NSAIDs. Again, these are the data from the Precision trial. I've showed you corticosteroids. This is this large meta-analysis. So clearly medicines may be part of the story. These are data about IL-6 and IL-18. IL-18 is downstream of the IL-6 pathway. IL-1, IL-6, IL-18 all impact CRP. CRP kind of being an epiphenomenon is what most of us believe. And these are data from the CANTOS trial that were recently published in European Heart Journal. And these are data from baseline tertiles of IL-6, tertiles of IL-18, and at 3 months. And what this publication from Ridker et al. Is showing is that as you increase IL-6 and IL-18, the hazard ratio for cardiovascular events goes up. So both of these aspects of the same pathway seem to be important and have an additive risk. And so we can imagine that blocking IL-6, perhaps blocking IL-18, as well as what we've seen in CANTOS, might be potential strategies for cardiovascular disease modification. We know that IL-1 is incredibly important in RA. It's interesting to note, and the rheumatologists know these data well, that IL-1 blockade with anakinra has not been tremendously effective in patients with RA. We occasionally use it, but that we have many better agents. But we know that IL-1 is important in the pathophysiology at the joint. It's macrophage derived. It induces IL-6, IL-18, GM-CSF, induces MMPs, ICAMs, and it's important for osteoclast maturation. We also know, I've showed you this cartoon already, that IL-1 is quite important in this whole pyroptosis and downstream signaling for cardiovascular disease, as well as for gout and other of our crystalline-based rheumatic diseases. We also know that IL-6 is quite important in rheumatoid arthritis. It's generated at the joint level, and fibroblast-like synoviocytes and macrophages are important in generating IL-6. It's active against T and B cells. It drives the CRP, and it's important in many of the pathways that are quite active. We know that at the atherosclerotic plaque, IL-1 and IL-6 are generated, impacting many downstream factors in the atherosclerotic plaque rupture and other aspects of thromboembolic disease. There's also a very interesting development in the genetics world. This is the clonal hematopoiesis of indeterminate potential, or CHIP. This is specific mutations that result in CHIP and associate, we know, with older age and leukemia. And however, there's this indeterminate level of CHIP. It's described as greater than 2% of these mutations. And most of these mutations occur in these 4 genes. And we know that some of these genes are important in cardiovascular disease. We know that TET2, JAK2, et cetera. And there's a 40% increased risk, cardiovascular risk, among the general population who exhibit CHIP. And interestingly, there's this growing evidence of CHIP in rheumatic diseases. There's several studies in RA suggesting a possible increase in CHIP and RA. So there may be genetic linkages between RA, cardiovascular disease, because of mutations and because of other shared genetic backgrounds. Coming back to this lipid paradox, which I talked about before, there's a burgeoning literature on oxidized LDL in patients with RA. This is a observational study from last year on 450 patients with early RA, showing that oxidized LDL is strongly correlated. We know it's correlated with CVD, but the ratio of oxidized LDL to LDL seems to go up with patients with high disease activity with RA. And we know that as LDL levels decrease, this ratio, as the ratio decreases, the LDL levels go up. So this may be part of the reason why we see this lipid paradox, that it's about the ratio and not the absolute LDL level. And I know there's a lot of people in the lipidologists that I work with here at the Brigham that are very focused on this hypothesis and thinking that this may be part of why we see systemic inflammation having an inverse relationship with LDL levels. This all brings me to this kind of summary slide from a recent kind of review article by some colleagues here at the Brigham, showing how there's many different pathways that are being considered from a therapeutic standpoint. We already know canakinumab and the other IL-1 receptor antagonist anakinra. We know about TNF blockade. We know about IL-6 blockade. There's active work on IL-6 blockers in cardiovascular disease, some trials getting underway. We already know about some of the work on methotrexate as well, some other agents that are people are considering, and then others listed here. And so I think that this area of how immunomodulators impacts athero in the general population is just going to grow and grow over the next decade. Again, I know this is a very active area. So in conclusion, inflammation predicts athero, but still unclear if treating inflammation in patients with RA reduces CVD. It likely does based on a lot of epidemiologic data, but we still need more experimental data on this. Patients with RA are at increased risk of all forms of cardiovascular disease, including DVT and PE. I didn't show you data on heart failure, but it appears related as well. Traditional CV risk factors tell part of the RA CVD risk story, but systemic inflammation, otherwise known as RA factors, also underpins risk. And lowering RA disease activity likely reduces the CVD risk, but different treatments may differentially impact risk. So how do I think about this when I go to the clinic, such as this afternoon? I'm going to think about having a low threshold for preventative CVD treatments, such as statins, and working patients up who have systemic inflammatory conditions for cardiovascular disease. And here at the Brigham, we have a cardiovascular disease in rheumatology clinic. It's a virtual clinic, but we send 3 or 4 of our cardiovascular colleagues, these patients who do kind of a standardized workup and do some testing. And a lot of these patients end up on preventative treatments such as statins. Aggressive disease control in RA is likely to lower CV risk and should be discussed with patients. Long-term steroids likely raise CV risk and should be avoided whenever possible. I spend a lot of time talking to patients about less steroids, not more steroids. NSAIDs and COX-SIBs are contraindicated in patients with recent CV events or known cardiovascular disease. Having said that, I clearly use them. I talk about the risk. I make sure patients understand the risks before prescribing them. And these risks, are important for the general population as well as in rheumatology. And more systemic immunosuppressants are coming for CVD in the general population, as I've said. So I will stop there, say thanks for your attention, and glad to take any questions.
Great. Thank you so much, Dr. Solomon. That was a fantastic and insightful talk. Anybody has any questions or comments, you can post them in the chat, or alternatively, you can unmute yourself and go ahead and offer your comment or ask any questions. I'll go ahead and offer a question, especially based on your last couple slides. And given the proposed link between inflammation, atherogenesis, and lipids with cardiovascular disease risk in RA, and particularly with the evidence that you showed for the use of statins, wondering what your targets are of treatment when using statins. And as a corollary, we use other risk stratifiers in patients without RA when we're deciding about either starting treatment or continuing or being more aggressive with lipid lowering therapy like Lp(a), ApoB, or CAC scoring. So I'm wondering if you have any insight into use of those risk stratifiers.
Yeah, no.
I have a question. This is Vimal Sudani. Doctor, I have a question. When you use the statins, how do you get muscle pain? How do you reduce the muscle pain?
Sure. Let me take both those questions. First, let me take Dr. Cohen's question. I think I use the same general population targets for LDL. So, trying to drive LDL, down to below 70, 60, depending on, the risk of the patient. The other, coronary artery calcium scores, we do use that again as a risk stratifying tool in people at intermediate risk. Some of the other factors, Lp(a) and others, again, I think we think about our rheumatoid population as being a high risk general cardiovascular population with a accent on inflammation. So we want to lower their inflammation as rheumatologists. Lowering their CRP is important. So I have patients that come in and say they feel well from the standpoint of their RA. They're quite functional, but they still have CRPs that are, hsCRPs that are above 10, and I'm talking to them about trying to lower it. So I do occasionally add treatments to lower inflammation, even though a patient says they feel pretty well. But again, when I risk stratify them from a cardiovascular standpoint, or even from a RA standpoint, I know that patients with ongoing inflammation are at risk of worse RA outcomes as well as cardiovascular outcomes. So I think that we use all the risk stratification tools available to us. However, many of them haven't really been proven in RA, they're active areas of inflammation. The other question about muscle pain, clearly muscle pain in RA is a tricky issue. I see a patient, I just saw him yesterday. He has polymyalgia rheumatica, started on a statin, and it felt worse. And was it the statin or was it his PMR? And so these are difficult clinical questions. I don't know if there's easy answers for those. I think that statin muscle pain we know happens. We know that elevations in CPK are rare. They do happen for a variety of reasons. I always, I'll try to stop the statin. I'll put the patient back on statin. We'll change statins. Occasionally use non-statin lipid lowering agents, with input from cardiovascular colleagues. But, I use a lot of statins as a rheumatologist. Honestly, I don't use them because they lower disease activity much. They lower disease activity a smidgen, not that much, but they lower it a little bit. I use them really for cardiovascular risk prevention, but I do so usually with collaboration from a cardiologist.
Thank you.
if anybody has any other questions or comments, you can go ahead and post it in the chat or unmute yourself. Otherwise, we can end a minute or two early before 9 a.m. Dr. Solomon, thank you so much for your time, and it was a wonderful talk.
Great. Thank you.
Thank you very much. Have a great day.